Hi guys, thank you so much for joining the first Mind the Crash Bleep webinar. We're scheduled to start at 7 o'clock, but we'll wait a few more minutes till about 5 past, just to see if anyone else is going to join. Okay, it's 7:05, so let's make a start. My name's Luke Austin. I'm a registrar in anaesthetics and ICU. And this is the first in the Mind the Crash Bleep series of webinars, so thank you so much for joining live, and also to everyone who's hopefully watching in the future as well. All of these will be recorded to watch back on YouTube afterwards. The idea of Mind the Crash Bleep is to do an adult emergency case presentation, but rather than just talking through in a sort of didactic lecture style fashion, we'll stop along the way to increase active learning and give everyone a chance to think about what they would do next in that particular situation, to consider the options and think through that particular point in the case. There'll be time for discussion and questions afterwards. And we'll also pause to mentally rehearse the relevant algorithms or guidelines or even procedures as we go through the particular case. So this is a quote that I thought was really useful. The best simulator in the world is the human brain. This is from Professor Peter Brindley, who's an anaesthetist in Canada. And I think it tells us that by working things through in our heads beforehand and putting ourselves under a bit of pressure mentally, whilst we're actually in a safe space before an emergency has happened, we can increase our performance when the real thing comes along. So what's the evidence for this whole mental rehearsal thing? There's a few studies. So in novice surgeons, mental practice before a virtual reality cholecystectomy really improved performance versus a control group who just had a lecture. That's from a study in 2011. And surgical cognitive simulation improved trainees' real-world performance on a surgical curriculum assessment that was done 4 months later. That was from 2021. So those ones are from surgery trainees, but what about something a bit closer to which we're talking about, being resuscitation? Well, in 2016 there was a study where residents were randomised to be in a group that either received 20 minutes of mental practice or 20 minutes of traditional ATLS instruction before taking part in a subsequent high-fidelity trauma resuscitation simulation. And those that did the mental practice outperformed the people that did the traditional ATLS instruction. So it's worth giving this a go, and to get the maximum benefit from this strategy for learning, try to buy into it and imagine the emergency that we're going to do playing out in your own place of work, in one of the hospitals that you're maybe working in at the moment or have worked in the past. Alright, so here we go, let's give it a go. So it's a night shift, you're on call for acute medicine, you're carrying the crash bleep, and you get 2222 adult emergency to the CCU. So you get there, and on arrival, we have a 52-year-old gentleman called Dave, who's day 1 post-elective PCI to the LAD, so it was done yesterday. So the day of the procedure is day 0, and day 1 is the day afterwards. He looks unwell. His past medical history is he's an ex-smoker, he's got hypertension, he's got elevated cholesterol, type 2 diabetes, and end-stage renal failure. And I'll give you a moment to think about how you will assess this patient. Okay, so I think most people will probably say, oh, I'm going to do an ABCDE assessment, correct? So let's walk through it. So airway is self-maintaining. When you examine B, you stick a SATS probe on. He's got SATS of 92% on a couple of litres of oxygen via nasal specs, and there's a few coarse creps in both bases of the lungs. His blood pressure is not too good. He's got a blood pressure of 81/45, a bit tachycardic with a heart rate of 106, no murmurs, and he does look slightly clammy. His GCS 15, his pupil is equal and reactive to light, and his capillary glucose that one of the nurses does for you is normal. And his belly's soft, his calves are soft, and the temperature is normal as well. So the next thing is, what investigations would you like to do for Dave? Okay, so he's hypotensive and day 1 post-PCI. So I think most people will have said an ECG for starters. So here's his ECG, which is borrowed from Life in the Fast Lane. And I'll give you a moment to have a look at that. You also decide to order a portable chest x-ray. So one of your colleagues calls for them and they're on the way, but they say they're quite busy in resus and they're going to be a few minutes coming up. So you're a bit worried about the state of this ECG, with the obvious feature being these tall tented T waves, and you go on to take a gas from the patient, and here's the blood gas. So give you a bit of time just to look through that gas. And the feature that really jumps out, isn't it, is that potassium of 8.1. So have a think about now what you're going to do next. Okay, so hyperkalemia, a medical emergency. I think most people will probably be saying things like the following: some IV calcium, some insulin dextrose, maybe a salbutamol nebulizer, perhaps informing the renal registrar and considering renal replacement therapy for this patient, remembering his background of end-stage renal failure, and someone might even suggest sodium zirconium cyclosilicate, otherwise known as Lokelma, an oral potassium binder. So out of these ones, really the potassium binder is not really relevant because this is too acute and that's going to take too long to work. But all the rest are sensible. So clearly the priority with a potassium this high in an unstable patient who's hypotensive and with a dodgy heart anyway from his procedure is to protect the myocardium. So I'll give you a moment to think about what calcium you're going to prescribe. Okay, so this is not designed to be a trick question, and I've actually highlighted both C and D as possibly correct to lead on to a bit of a discussion about these two different formulations of calcium and the key differences between them. So I think either would be justifiable in this situation, either 30 mils of 10% calcium gluconate or 10 mils of 10% calcium chloride. So let's have a think about these two different formulations. On the left-hand side of the table, we've got calcium gluconate, and on the right-hand side, we've got calcium chloride. The first thing to say is that the ALS dose of calcium gluconate is 30 mils, and this is often got wrong. Often people will be giving 10 mils of 10% calcium gluconate, and an emergency such as this is just not enough. The reason for that is that you need to give 3 times as much gluconate as chloride to get the same amount of elemental calcium. And you can see in this table the milliequivalents of calcium per gram of the drug, which is, and you'll see that 4.65 is about a third of 13.4, which is why you then need to give 30 mils of the calcium gluconate compared to only 10 mils of the calcium chloride. They also are prepared quite differently. You'll see this calcium chloride is in a mini jet, which is in the emergency drugs box in most hospitals, and it almost looks like the adrenaline mini jet for cardiac arrest, doesn't it, except that it's bright blue. Whereas calcium gluconate usually comes in these plastic ampules, which in some cases sort of look worryingly similar to saline ampules. So what are the other important considerations when thinking about which of these two you're going to use, other than the dose? So the first thing to say is that in terms of the IV access, calcium chloride really needs to go in either a central line or a big vein. It's perhaps more important to think about the size of the vein that you're using rather than the size of the cannula. This is to do with the risk of tissue necrosis, ulceration, and calcinosis if the vessel is too small that you're putting calcium chloride into. The next thing is this issue of the administration time. With 10% calcium gluconate, it can be given neat without being diluted, but it has to be given over 10 minutes. Whereas calcium chloride can be given a little bit faster, over 3 to 5 minutes, according to the BNF. So I think you could justify either one of these answers for this particular question for Dave. It would depend on what size cannula you could get into him. And I also think that you could justify perhaps using the calcium chloride if you've got a big enough cannula and a big enough vein, because his potassium's over 8, he's really sick, and you can get the calcium chloride in a bit quicker than you can the calcium gluconate. The other note to say here is that it's important if you're giving some bicarb, perhaps because the patient's also acidotic or has got end-stage renal failure such as Dave, don't put the calcium through the same IV line as the bicarb because they can precipitate together. Lastly, calcium gluconate has in the past been said to require good liver function to activate it and therefore exert its effect, but this is actually a myth that's been debunked. So in liver patients you can still use calcium gluconate. And I just thought I'd put this on screen here, which is, again, this has come from the BNF, and I think it's a really useful thing to have a quick read through about the advice for potential underdosing with calcium gluconate in severe hyperkalaemia. Even just the other day, I had a patient with a potassium of 10 in ED resus, and an ED consultant saying that we should just give 10 mils of calcium gluconate, and the dose is too low. Lastly, an important point when considering calcium for stabilisation of the myocardium in severe hyperkalemia is this issue of redosing. If the ECG changes are persisting after 5 to 10 minutes, it may be necessary to give further calcium. And equally, if the patient's still unstable and the potassium hasn't been proven to be lowered, the calcium may need to be redosed after 30 to 60 minutes. The point it's making down here at the bottom is that calcium should be used when you've actually proven hyperkalemia, and it's not something to just give in any old cardiac arrest when the potassium is normal. Okay, so salbutamol can also be used to sometimes, not always successfully, push potassium back into the intracellular space via its beta agonism. So have a think about what is the dose for nebulized salbutamol in hyperkalemia. Okay, and then just whilst people are having a think about that one, I can see on the chat on YouTube Live we've got a few questions coming in, which is great, so keep them coming. So the question here is, practically with calcium gluconate, how would I administer it over 10 minutes? So the suggestion here is perhaps 3 ml per min via a syringe. So what I do for gluconate is it's going to be 10 mils, isn't it? So it comes in 10 mil, usually 10 mil in each ampule. And the dose being 30 mils. So you can either, you're probably going to have either a 10 mil syringe and a 20 mil syringe, or 3 10 mil syringes. So it's going to be total 3 mil per minute, isn't it? Sometimes when I'm trying to give these meds safely, I even get out my iPhone, put the screen to be fully unlocked and leave the timer running, and then every minute, push, say, the 3 mils. And then give it a bit of a flush with another syringe of saline, wait another minute on the timer, and when you get to minute 2, then push the next bit. I think this patient would be unstable enough that if I was doing this on a ward, I'd probably we'd have the crash trolley in the bed space, and put the pads on and have the patient on, then set the defib to monitor mode, and then you've essentially created a bedside cardiac monitor for yourselves in double quick time, which is a useful technique if you find yourselves doing this in a ward that doesn't have cardiac monitoring. I think for Dave, who we're talking about, Dave is day 1 post PCI and he's on the CCU, isn't he? So he would hopefully be in a monitored bed already. But doing this on a normal ward, that technique of turning the defib into a portable monitor can work quite well. So yeah, I think so. So the gluconate is going to go in over 10 minutes, isn't it? The calcium chloride that bit faster. The other thing is that the calcium chloride sometimes is just a bit easier to get it faster because it's in the emergency drugs box, along with the adrenaline and the amiodarone and so on. Whereas the gluconate, the nurses might have to go to the cupboard and sort of scramble around for it. Okay, so back to the salbutamol. So surprisingly, the answer is actually 10 to 20 milligrams for salbutamol and hyperkalaemia. So it's a lot higher than the asthma dose, and it's a lot higher as a nebulizer dose than the nurses might be used to giving. But that said, in our particular patient, Dave clearly has ischemic heart disease and he's day 1 post PCI. So in those with ischemic heart disease, you do have to be a bit cautious because of the possible effects of beta agonism on the myocardium and increasing the oxygen demand. So I think for Dave, actually, in his particular situation, 10 milligrams would probably be the top dose. And this salbutamol and hyperkalaemia is really an adjunct of something you can do whilst the other things are happening, as long as there's no other contraindication. It's not the mainstay of the treatment, as we know. The mainstay being the calcium chloride, and then following that up with the insulin dextrose infusion. So here we go. So scenario gets a bit more difficult now, and the team members say, "Oh, we're really sorry, we can't get cannula in anywhere." And I'll give you a short moment to think about your options. And let's make this a bit more difficult and say, the anaesthetist hasn't turned up yet to the crash call, and no one can find an ultrasound on the ward either. So Dave's really looking pretty rough now, and you're very worried about this potassium of over 8. So you decide that you're going to place an intraosseous needle. Now, I think most people here on the call will have done the ALS course. Maybe not if you guys are still medical students, but I imagine quite a few of us on the webinar have done ALS by now. But for lots of us, it's been a while since we've actually done an IO, so I'll give you a short while to try and cast your mind back to ALS and think through that procedure in your mind's eye of how you're going to approach it, where you're going to go, and how you're going to place that intraosseous access. Okay, so having had a bit of a time to think about this IO technique, let's have a look at a tutorial on how it's done. Hopefully the sound is going to work on this. If the sound doesn't come through, just let me know in the comments on YouTube, okay?
For the proximal tibia, you want to feel 2 finger breadths below the tibial tuberosity, and you're going to go on that anteromedial surface. So you're going to prep the skin, of course, first. Now with your drill, here they're using the yellow one. The blue would also work. Yellow might be a little long, so you just don't want to hub it. You're going to advance it through the skin and then drill until you feel give. That's how you know you're in the medullary cavity. Don't push it beyond that because you don't want to go through the medullary cavity. Now you remove the stylet and you can place that fancy, beautiful dressing. And now you can hook up your tubing. So they're going to draw off some labs here, which is great for things like H&H and type and screen, but some of your elements of your chemistry panel are going to be very different from your serum levels, so you want to be careful. And remember, you can give any medication through an...
Oh, great. So the sound's working. I'm very happy about that. It took a bit of figuring out to work out how to get these YouTube clips to embed into the slides for the YouTube live presentation. So that's great. So yeah, hopefully that was a useful reminder for you of the tibial IO. These obviously can go in the proximal humerus as well, but the times I've done this, I've found that in peri-arrest situations on the ward, usually the leg is just a bit more stable on the bed and a bit easier to get at and a bit easier to feel the landmarks for compared to going for the proximal humerus. Okay, so this is bad news. Whilst you're doing that and your IO's just gone in, Dave suddenly becomes unresponsive. I'll give you a short moment to think about what's going to happen next. So you're already there as a crash team, you've already had the 2222 call put out. So you decide to check for signs of life, open the airway, and look, listen and feel for breathing for a maximum of 10 seconds. Nobody can see any breathing, no one can feel a central pulse, and CPR is started. You've already got the pads on, and the team leader says, guys, let's stop and do a rhythm check. And here is the rhythm that you're going to see on the monitor.
Changes in levels of...
Oh, sorry, there we go again. Here's the rhythm on the monitor. So that's your rhythm, it's VF, and you decide you're going to shock the patient. So again, it's for some of us have done defibrillation more recently than others. Some people might want a bit of a reminder. So this is a Zoll model to look at, and I'll give you a short moment to think about how you're going to use the buttons and deliver the shock.
In the case where you need to shock a patient, you will turn the monitor onto defib setting. The monitor will default to 120 joules, which is the recommended joules on this device for the first shock. After the initial shock is placed, you will see the joules increase. As you see here, the joules automatically increased from 120 to 150. This will increase up to a maximum of 200 joules.
Okay, so that's the monitor, and I thought we'd also just watch a quick reminder from the Resus Council of delivering safe defibrillation. I'm just going to have to change tabs to do this, so give me a moment. Okay, so hopefully here we go.
Excellent. Defibrillation. Keith, we're about a minute in. If you can just check the timings for me, please. He's had one shock already. Bill, can you get me the patient's notes, please?
20 seconds until the next 2 minutes.
20 seconds till we're coming in. So at that point, Amita, I'd like you and Yanni to swap over within the rhythm check, okay? So we're going to swap over at that point. And Keith, I'm going to hand over to you to deliver the shock.
Absolutely. We're at 2 minutes now.
Stop CPR, please. Looking at the monitor, that's a shockable rhythm. Straight back on the chest, please. Over to you, Keith.
Lovely. I'm going to charge the defibrillator. I'm not going to shock yet. Remove the oxygen and everybody else step back. Charging. Head is clear. Bed space clear. Amita, in a second I'm going to ask you to stand clear so I can deliver the shock.
Yep.
And then I'm going to ask you to immediately restart CPR. Are you happy with that?
Yep.
Stand clear. Shocking now. Restart CPR.
Excellent, thank you. Okay, so we're in a shockable rhythm.
Okay, so hopefully that was a useful reminder of the sort of choreography of delivering a safe shock in the bed space with lots of people around. And you continue on the shockable side of the ALS algorithm. So time equals 0 was your initial rhythm check. It was VF, first shock delivered. CPR continues for 2 minutes. At the next rhythm check, it's still VF, and the second shock is delivered. And at the next rhythm check after another 2 minutes, it's still VF, and a third shock is delivered. So after 3 shocks have been delivered, you'll remember that we give amiodarone, 300 milligrams via the IO that you've placed, and also the adrenaline. And also, it's worth remembering that on the shockable side of the algorithm, no drugs at all until those first 3 shocks have been given. So, someone in the team asks, can we give the hyperkalaemia treatment in cardiac arrest? And I'll give you a moment to think about that. So yeah, the answer is yes, you can. And there's just some modifications about how you're going to do it and how you're going to give the treatment once the patient has actually arrested. So on the left-hand side, I've just taken a picture of the manual here for us to remind ourselves. And you didn't. This is this is all happening quite fast. And you remember you placed your IO needle, but before you could actually give anything, Dave went and arrested. So you've done a bit of the algorithm now. You've done the first 3 shocks. So you can now give that calcium chloride down the IO or an IV if you've got one. And the difference here to notice is that once a patient is in cardiac arrest, the book allows you to give the calcium chloride by rapid bolus injection. And again, following on from our discussion of calcium chloride versus calcium gluconate, in cardiac arrest, use the calcium chloride. Try and shift the potassium into cells. So it says here in the book, give glucose and insulin, 10 units of rapid-acting insulin, short-acting insulin, and 25 grams of glucose by rapid injection, and then monitor the glucose afterwards. So just a bit of a reminder of the sort of the conversions involved here. It says 25 grams. So if you remember that a 1% solution is 10 milligrams per mil. So a 10% solution would be 100 milligrams per mil. And therefore a 50% solution would be 500 milligrams per mil. So 50 mils of 50% glucose gives you the 25 grams that they're talking about here in the book. And lastly, I think this does apply to Dave because of his end-stage renal failure. He's going to get 50 mils of 8.4% sodium bicarbonate by rapid injection, but as we discussed, not through the same line as the calcium. So you can only give this one if you either place another IO or someone's managed to get a cannula into Dave by this point. So the fact that Dave is still in cardiac arrest after 3 shocks and he's been VF each time makes him in refractory VF. And I'll give you a moment to think about what you're going to do next, given that you're in a refractory VF situation. So what the ALS manual recommends for refractory VF is a switch to the AP, the anteroposterior pad position. Getting this done logistically takes a bit of prior planning, so if you're still in a shockable side of the rhythm after 2 shocks and you're approaching a 3rd one, it's worth starting to brief the team as a team leader and to start planning for a switch of pad position if you think that's the way things are heading. So let's watch this video about placing the pads AP.
Roll the patient onto their side and then roll the electrode onto the patient's back to the left of their spine and under the scapula. To apply the front electrode, grasp the triangular blue electrode labeled 2 and peel it from the liner by lifting at the red tab at the base of the electrode. The one-step complete and one-step CPR electrodes include a CPR compression sensor. Place the sensor on the patient's chest so the vertical red line is mid-sternum and the horizontal red line is between the patient's nipples. Roll the electrode onto the patient's left chest with the blue triangle midway between the sternum and nipple. For female patients, lift up the breast if necessary in order to position the electrode underneath.
Yeah, so it's a tricky one. I have been in this situation a couple of times of needing to switch to anteroposterior pad position. The key is to have the whole team on board and get people ready to do a roll. And usually the way to do this is to actually get a second set of defib pads. That might mean going to get another crash trolley from further down the ward or even from a different ward. It's just not going to be practical to peel off the existing pads because they're so sticky and then replace them in the new position. The easiest thing is going to be to get a brand new set of pads that are going to go AP, and then you'll change over which set of pads are connected to your existing defib. So you continue on the algorithm with your pads now anteroposterior. So 6 minutes in, it's still VF, and you get a fourth shock. 8 minutes, next rhythm check, it's still VF, and you give a fifth shock. And take a moment at this point to just remind yourself of how much amiodarone are you going to give now after the fifth shock has been delivered. So yep, it's 150 milligrams. It's half the 300 that you gave last time. And your adrenaline. And as CPR continues this time, your anaesthetists, they turned up about when Dave arrested. They've come, they've put an eye gel in, and they're squeezing the bag. And they attach a sort of one of their portable end-tidal CO2 devices to their eye gel, and they tell you that this time in this cycle they've actually noticed a rise in the end-tidal CO2, and lo and behold, at the next rhythm check, you have a perfusing rhythm that you think, oh, is it PEA? But actually you can feel a pulse with it, so it's a ROSC. So everyone's very happy that Dave's got a ROSC, and now consider in your mind's eye at this point, you've got a pulse come back, the anaesthetist is squeezing the bag. What else needs to be done for Dave? What are your next moves at this point? So I think Dave is going to get the standard post-ROSC care that we've learned about in ALS. He's going to get an A to E examination again from the top. He's going to want another blood gas doing now that he's ROSC'd, and I think assuming that he's a candidate for ICU, which although he's a bit comorbid, he probably should be given he's day one post-procedure and not so old, he's likely going to get intubated on the ward. Considering now the etiology of the cardiac arrest, the team starts to talk about where should we take Dave now? Does he need to go to the renal dialysis unit? What about staying on CCU? Does he need to go back to the cath lab? Or should he just go straight to the ICU? What do you think? So I think for Dave being day one post-PCI, a key issue to exclude is whether there's anything ischemic on his post-ROSC ECG, and whether there's anything that cardiology are going to see on that ECG that would make them want to take him back to the lab. The top differential for this cardiac arrest seems to be the hyperkalaemia, which he'd proven before he arrested, and the potassium of 8 is clearly high enough to induce a cardiac arrest. He also was a bit clammy and unwell, wasn't he, beforehand, but he wasn't complaining of any chest pain. And when you do the post-ROSC ECG, the cardiology reg has rocked up by this point, and says that he doesn't think there's anything acutely ischemic on it, so he doesn't need to go back to the cath lab. The anaesthetists have now tubed Dave, and then they decide to take him to the ICU. Clearly, the treatments we discussed for the potassium are just a temporising measure, and they've pushed the potassium back into those cells, but it will leak out again, and his kidneys aren't working. He's an end-stage renal failure patient, and you realise through perusing the notes that what's probably happened is Dave missed his usual dialysis session yesterday because he was in his PCI. So Dave's someone that normally dialyzes 3 times a week. He's missed his dialysis, and that's the explanation for why his potassium was so high. So what he actually needs to do is go to the ICU, be lined up with a VAS cath, and get filtered on the unit. So Dave is taken off to the ICU. The medical emergency team have all done an extremely good job, and everyone has a debrief about it. And I'll give you a moment to think about what sort of key learning points from the case of Dave's resuscitation that you might take forwards. So one thing that I thought was a particularly interesting part of this resuscitation that relates to a quite recent trial published in the New England Journal of Medicine was the issue of the vector change defibrillation, switching from the standard anterolateral pad position to the AP pads. This trial actually investigated 2 different strategies for refractory ventricular fibrillation, the vector change going AP, but also this thing called double sequential defibrillation, which is essentially where you put the second set of pads on with a second defibrillator, and the patient gets sort of 3, 2, 1 shock from the first defibrillator with the first set of pads, and immediately followed by another shock from the second defibrillator with the second set of pads. So this was called the DOSE-VF trial. It was a pre-hospital trial in Canada, which was called a cluster randomized crossover trial, where actually what they were doing was randomizing the groups of paramedics rather than randomizing the patients. So I think there were 6 paramedic services, and those paramedic services would sort of rotate between them who was doing what strategy for refractory VF. Some of them were carrying on doing the normal thing with standard defibrillation after the 3rd shock had failed. Some of them were doing the switch of pad positions, which we've seen with Dave, going AP after the 3rd shock had failed. And some of them in the other group were doing the double sequential defibrillation, shock, once they entered refractory VF. So this is just a diagram that illustrates a little bit better the 3 different groups in this trial. So you can see here the standard defibrillation with a normal pad position, vector change defibrillation going AP, and lastly double sequential defibrillation, where you have your anterolateral pads and then you add in the AP pads and have 2 separate defibrillators to go shock. So unfortunately with this trial, one of the limitations was that due to COVID, they didn't quite recruit the number of patients they needed to according to their power analyses, but nevertheless the data were very interesting. And if you think about your chain of survival that you consider in ALS, from terminating a shockable rhythm to getting a ROSC, surviving to discharge, and then which fraction of those people actually have a good neurological outcome. I think what was interesting about this trial is that you can see in each of the groups how the percentage of people in getting to each of those stages steadily decreases. However, there was a significant increase with both the vector change defibrillation and the double sequential defibrillation in each of these stages compared to standard. So you can see that termination of VF was much higher, termination of refractory VF was much higher with both vector change and double sequential. Vector change and double sequential got more ROSCs, and vector change and double sequential got more survival to discharge and more neurologically intact survival. At the moment, the state of play in the UK is that vector change defibrillation is in the ALS manual and is the recommendation after 3 shocks have failed, but double sequential is not yet recommended, and I think there are sort of further considerations from the guidelines committee before this actually gets introduced into clinical practice in the UK, but it's nevertheless a very interesting paper to have a look at. So if anyone's got any questions from the case or things they'd like to ask, just pop them in the chat on the YouTube Live, and I'll do my best to talk them through. So if nobody's got any further questions, it just remains for me to sort of tell you about the system for getting a certificate from this webinar. If you go onto the Mind The Bleep website, so www.mindthebleep.com/webinar feedback, you fill out the feedback form specifying which webinar it was you attended, and the system will generate a certificate that will be sent to you. This is the first time we're trying the Mind The Crash Bleep series. It's the first time going through things in this format, so let us know what you thought, let us know if it was helpful, anything that you think can be done differently and what we can improve about it to make it more useful. On that issue to read about, you might be interested to see the Academic Life in Emergency Medicine post about the differences between calcium gluconate and calcium chloride. That's a Mythbusters post talking about that sort of previous belief that you needed really good liver function to be releasing the calcium gluconate, and then the New England Journal of Medicine paper about the defibrillation strategies in refractory VF. And there's also a good post about that on the Bottom Line site. So hopefully that was really useful. Hope you enjoyed it. We'll be doing the same time next week, Monday at 7 PM for the second webinar of Mind The Crash Bleep. If you have a case or an interesting resuscitation that you've been a part of, whether that's entirely real and you want to sort of adapt in patient details, or it's a fictional one that you've created in your head from parts of different scenarios, and you'd be interested in presenting a case on Mind The Crash Bleep, please do send an email to crashbleep@mindthebleep.com. Welcome. Thank you very much for joining, guys, and thank you for all the participation on the live chat.